A 67-year-old man arrives at the emergency department with severe lower abdominal pain and an urgent feeling that he needs to urinate but cannot. He explains that he has been struggling with urinary symptoms for years: weak stream, difficulty initiating urination, and frequent nighttime urination. But today, things suddenly got worse. He has not been able to pass any urine for the past 12 hours, and the discomfort has become unbearable. On arrival, he is visibly distressed, pacing slightly and holding his lower abdomen. His vital signs are stable, but he appears anxious and uncomfortable. On physical examination, his lower abdomen is distended and firm. Gentle palpation reveals a tense, bladder-shaped mass rising above the pubic symphysis, classic for acute urinary retention. A bedside bladder scan confirms a large post-void residual volume of over 900 milliliters. Given his age and long-standing urinary symptoms, the most likely cause is benign prostatic hyperplasia, or BPH, enlargement of the prostate gland that compresses the urethra and obstructs urinary flow. A Foley catheter is inserted, and immediately more than a liter of urine drains out, giving the patient almost instant relief. The urine is clear, with no signs of infection or blood. After decompression, the patient is monitored for post-obstructive diuresis, a condition where the kidneys produce large amounts of urine after a prolonged blockage. Once stabilized, the focus shifts to long-term management. BPH is first evaluated with a digital rectal exam, which in this case reveals a smooth enlarged prostate. A PSA test is ordered, and imaging such as renal ultrasound is used to assess for hydronephrosis or residual effects of chronic obstruction. Several treatment options are discussed. Medical therapy includes alpha blockers, which relax the smooth muscle of the prostate, and 5-alpha reductase inhibitors, which reduce prostate size over time. But because this patient presented with severe obstruction and long-term symptoms, surgical management is strongly considered. From a surgical perspective, the gold standard treatment is TURP, transurethral resection of the prostate. During this procedure, a resectoscope is inserted through the urethra to shave off excess prostate tissue, relieving the obstruction. Other options include laser vaporization, bipolar resection, or minimally invasive procedures like urolift, depending on anatomy and hospital resources. The patient elects for TURP. The operation successfully removes the obstructing tissue, and after a brief hospital stay with a temporary catheter, he is discharged home. Over the next few weeks, his urinary stream improves dramatically, and nighttime symptoms decrease. Key takeaway: acute urinary retention in older men, especially those with long-standing urinary symptoms, is most commonly due to BPH. Immediate catheterization relieves the obstruction, but definitive treatment often requires surgical intervention, such as TURP, to restore normal urinary flow.